Thank you, Mr. Chairman, and I would love to be at this moment ex officio to the Ag Committee, and I so appreciate your leadership and all that you're doing to express that we need trade and not tariffs.
Without objection.
Thank
Your
you.
comments are
Thank
in order.
you. I thank the witnesses and thank both my colleagues for this important hearing. Obviously, I wasn't here, Ms. Martin, when you gave your statement, but this statement by you about where you should live should not determine whether, if you live, resonates in lots of my state.
One question.
The access to healthcare through the Medicaid expansion was big in rural communities in my state. Writ large, 600,000 people in our state got expanded coverage. But we have counties like Douglas and Chelan where, again, so the chairman knows where our apple and cherry and pear industry is located. They have seen an uninsured rate drop more than 60% thanks to that Medicaid expansion. So I just wanted to ask about the importance of making sure that we keep that expansion and making the importance of not letting any kind of cap or reduction. Under this discussion that we had, CBO was saying that the previous proposals on block granting and changing Medicaid might cut as much as a quarter out of Medicaid over the next 2 decades. So is that problematic, Ms. Martin, for rural?
I think certainly the ACA expansion made a very positive difference in the community where my service area is, and I think in Colorado overall, we had a uninsured rate of nearly 20%, and that has been reduced in my community down to low single digits. And so the coverage for patients allows patients to get access to care. It's improved the financial bottom line of certainly our organization. I spoke earlier that 70% of our population is Medicare and Medicaid, so our relationship with government payers is critical to our survival.
Did you say 70?
70.
And ours is up there as well, over 50. I don't know what the latest numbers are, but yet I don't think people quite understand that that's the challenge we face. I mean, we love our rural economy and we love our rural communities. They're a great place for people who are aging to retire and live, and it's more affordable, but that means it's a different mix of the population as it relates to how you build a healthcare delivery system. So the Medicaid expansion is so critical to that. I also wanted to ask about telemedicine because that is another delivery system that I think for us, we have this Project ECHO, the University of Washington, working with Harborview. You've heard of it, obviously, probably in your state as well. But it's allowed medical professionals from Seattle to consult with people over in the Yakima Basin, some of our clinics, to talk about the decisions for really highly complex patients on for hepatitis C and substance use disorders. So how do we, what do we do about that as it relates to the payment system? Because I don't think fee-for-service is any kind of friend to that cost-saving technology and that cost-saving collaboration that's existing.
I think in our community, we're modestly beginning the use of telehealth, and part of our challenge is that we don't have the resources for a lot of the startup equipment, and some of the payment constraints don't allow us to be able to provide the service. I think one of the best things we could do is to invest in the startup expense for particularly for rural hospitals, and then allow the services to be reimbursed on a fair basis. We currently do telehealth now in our community for infectious disease, genetic counseling, and we're trying to build that for oncology coverage and for cardiology coverage, and it would actually save the system money. For instance, when a person goes into our emergency department, and we have one cardiologist in the community, when that person's not there, we have to, if the condition of the patients warrants, we have to transfer them to another area to be evaluated by a cardiologist. They oftentimes get transferred, are evaluated, and then they're dismissed from the hospital. If we could have cardiology services available 24/7, we would save the expense of an air ambulance or a ground transport for a patient with a cardiology problem.
Well, and there's no reason you can't with telemedicine, right? With that kind of technology.
Yes, ma'am, that's true.
So it's just getting this, getting it recognized into the system in some way.
And paid for.
Right, well, that's what I meant. Recognized into the system, and that's why the challenge that just a fee-for-service model challenge. For anybody, well, actually, I don't have any time left, but the doctor shortage issue for rural communities continues, and we just need to fight that. And so, you know, we have counties in our state that have very, you know, like 4,000 people and no access. So we've got to do better. Thank you.